Welcome. Have you ever heard of a rare lung disease where your lungs get filled with a milky, protein-rich substance? Today, we're diving into the fascinating and complex world of pulmonary alveolar proteinosis, or PAP. So, what exactly causes PAP? Well, it's not always straightforward. The most common form, autoimmune PAP, is usually triggered by antibodies that block the function of a crucial protein called GM-CSF, or granulocyte macrophage colony stimulating factor. This protein is essential for the proper function of alveolar macrophages, the cleanup crew in our lungs. In rare cases, PAP can be caused by genetic mutations affecting the GM-CSF receptor or surfactant proteins. Other causes include exposure to certain inhaled dusts like silica or aluminum, and even certain infections. But in many cases, especially with the autoimmune form, the precise trigger remains a mystery. Let's get a little more technical. The core of PAP lies in impaired alveolar macrophage function. These macrophages are supposed to clear away surfactant, a fatty substance that helps keep our tiny air sacs, the alveoli, open. When GM-CSF is blocked, the macrophages can't do their job efficiently. This leads to a buildup of surfactant and other proteins in the alveoli, creating that characteristic milky fluid. As the alveoli fill, gas exchange, that vital process of getting oxygen into our blood and carbon dioxide out, becomes impaired, leading to breathing difficulties. PAP is a rare disease estimated to affect only around 1 to 2 people per million worldwide. Autoimmune PAP is the most common type, accounting for approximately 90% of cases. It can occur at any age, but is most frequently diagnosed in adults between the ages of 30 and 50. There doesn't seem to be a significant difference in occurrence between genders, although some studies have reported a slight male predominance. The symptoms of PAP can be quite variable. Some people might have no symptoms at all, especially in the early stages. Others might experience a gradual onset of shortness of breath, often worsening with exertion. A persistent cough, sometimes producing thick, milky sputum, is another common symptom. Fatigue, chest pain, and even weight loss can also occur. In severe cases, PAP can lead to significant respiratory distress and even respiratory failure. Diagnosing PAP requires a combination of clinical suspicion, imaging, and laboratory tests. A chest X-ray or CT scan can reveal characteristic ground glass opacities in the lungs indicating the alveolar filling. However, the definitive diagnosis usually requires a lung biopsy, where a small sample of lung tissue is examined under a microscope to confirm the presence of the protein-rich material. Bronchoalveolar lavage, a procedure where fluid is washed into and then extracted from the lungs, can also be used to collect a sample for analysis. This fluid will typically appear milky and contain high levels of protein. Additionally, blood tests can be performed to detect the presence of GM-CSF antibodies in cases of autoimmune PAP. While pulmonary alveolar proteinosis is an umbrella term, we generally classify it into 3 main types. Autoimmune PAP, as we've discussed, is the most common. Secondary PAP arises from exposure to inhaled substances or other underlying conditions, such as infections or hematologic disorders. Congenital PAP is a rare genetic form typically presenting in infants or young children, often due to mutations affecting surfactant production or GM-CSF signaling. The primary treatment for PAP-A is whole lung lavage, a procedure where the lungs are sequentially and repeatedly washed out with saline solution to remove the accumulated protein. This is usually done under general anesthesia and requires specialized equipment and expertise. For autoimmune PAP, GM-CSF therapy, using synthetic GM-CSF administered through inhalation or injection, can be considered to stimulate macrophage function. In some cases, supportive care such as oxygen therapy and pulmonary rehabilitation might be necessary to manage symptoms and improve lung function. For secondary PAP, removing the offending agent or treating the underlying condition is crucial. Unfortunately, there's no specific way to prevent autoimmune PAP-E, as the underlying cause is often unknown. However, for secondary PAP-E, avoiding exposure to known risk factors such as silica dust, aluminum, and other inhaled toxins can be helpful. Early detection and treatment of underlying conditions can also reduce the risk of developing secondary PAP. The prognosis for PAP varies depending on the severity of the disease, the type of PAP, and the response to treatment. Many patients experience significant improvement after whole lung lavage. GM-CSF therapy can also be effective in some cases of autoimmune PAP. However, PAP can be a chronic condition, and some patients may require repeated lavages to manage their symptoms. In severe cases, PAP can lead to respiratory failure and even death. Recent research is focused on developing more targeted therapies, such as monoclonal antibodies that specifically block the GM-CSF antibody, as well as gene therapy approaches for congenital PAP. These advancements offer hope for improved outcomes and quality of life for individuals living with this rare lung disease.